Hello and welcome to Best of the Day, once again from the 50th annual meeting of the American Society of Clinical Oncology, once more in Chicago, Illinois. The meeting is winding up today. It's Tuesday morning and the final sessions will be over in just a few hours. But before everyone heads to the airport, we're sitting down with Dr. Govindan from Washington University Medical Center in St. Louis, which is also my hometown, and talking about metastatic non-small cell lung cancer and some of the interesting trials and studies that were presented at this year's meeting. So Govindan, thanks once again for coming to Best of the Day. It's always great to sit down with you and get your impact and your impressions on these studies.
Terrific. Thank you very much for having me. It's great to sit down and talk to you.
Well, good. Let's begin by talking about c-Met. And c-Met amplification and overexpression has been a topic in recent years. There are a number of agents targeting either the c-Met receptor or the hepatic growth factor ligand for c-Met, some that are targeting the tyrosine. There are tyrosine kinases targeting the receptor inside the cell. So one of the drugs that we've been watching for the last few years is onartuzumab, the single-arm monoclonal antibody that targets the extracellular portion of the receptor. There was data in phase 2 studies that looked pretty impressive in patients who appeared to be MET diagnostic positive by immunohistochemistry. So this was the phase 3 MET lung study that was presented this year. How did it look? Did that phase 2 data hold up?
Unfortunately, Jim, it didn't. So the bottom line is, in a group of patients with prior exposure to platinum doublet therapy, addition of onartuzumab, as you said, the anti-MET antibody, to erlotinib did not improve their outcomes compared to erlotinib alone. So clearly, this is not the right drug, or this is not the right population to study this drug in, and that's disappointing. And of course, like everything else, you can do the Monday morning quarterbacking and see what happened. Is it the drug, or we chose the wrong population, or we didn't really select the right biomarker? I think the answer probably is a little bit of everything. And is MET a bona fide oncogen? Is it something that we could potentially target? I think so. You know, MET mutations have clearly been associated with gastric cancer, hereditary papillary renal cell carcinoma, and MET has been known to be amplified in lung cancer, both before therapy and also after, in response to therapy, as a survival activating pathway. As you know very well, EGFR mutant patients, when they progress, at least about 15 to 20% of them seem to have significant MET amplification. So the fact that MET is a bona fide oncogen is not in doubt. So this drug did not work in the way we designed the study. And I'm not sure whether IHC is the way to go. For example, in the same session, we heard another presentation using MET amplification as a way of selecting patients using a very well-known drug, crizotinib. And it's a very small study, and it showed actually very impressive results in a very small number of patients, including some very impressive durable responses. So the challenge is to find the right patients here. And I think the MET amplification may be one way of selecting patients. And crizotinib should be studied in that population in a careful manner, and that's a study that was presented at the ASCO meeting. So the important take-home messages from these two presentations are MET antibody did not work, the Genentech MET antibody onartuzumab, in combination with erlotinib in this fashion. MET amplification is perhaps one way to select some patients, and crizotinib probably would be an important drug in a small population of these patients. How often is this seen? My sense is that it's a very small number in the initial untreated patients. We also found MET mutations in some of these patients. In fact, there is going to be a paper coming out in Nature from our work from the Cancer Genome Atlas project. We did find some exon skipping events that really activated the MET pathway. What would be the right drug? Only time would tell. a lot of drugs are in play here, and I think eventually this would be a target we'll be seeking. This will be a group that will be going after with targeted therapies.
Well, Onartuzumab's parent company has obviously spent a lot of money in this clinical trials process. Are they likely to go back and repeat some of these studies in a MET amplified population, or is this drug just going to wither away?
I don't know. I think we should go back to the drawing board and ask this question. MET amplification may be an important thing, but what's the right drug to use? Is it the small molecule like crizotinib, or is it an antibody? I don't know, Jim, to be honest with you. I don't want to speak for the company, but I really think before we go on to do another study, we should really have some strong preclinical data.
Very good. Well, one of the other areas, crizotinib, as you were mentioning, is a MET inhibitor, but it's also an inhibitor of the ALK fusion, the EML4 ALK fusion rearranged protein, and it's shown remarkable activity in that area, but the responses, like in many situations, are self-limited, and eventually patients become resistant. So the LDK378 drug has been looked at over the past few years. Ronnie Mera presented some of the data a couple years ago at ASCO, and now this drug, now called ceritinib, has been approved for crizotinib failures. The question as to whether or not it should be moved to upfront or stay as a second-line drug. But there was updated data with their ASCEND-1 trial presented again at the oral session this year. So tell us a little bit about that and how strong the data looks for that drug.
Sure. What is impressive is that ceritinib, or the LDK378 that you're mentioning, clearly has activity in both in the front line and in the crizotinib failure patients. But we have to remember that the approval now is only for those who have failed crizotinib. And that's where I see myself using the drug currently. But the updated data look as impressive as the original data we saw a few years ago. Clearly this seems to have activity in both these groups of patients. Only time would tell whether using ceritinib upfront over crizotinib would be better. And unless we have clear head-to-head randomization, it's hard to say. But definitely this looks very impressive. The important point is that we have to pay attention to toxicities, right. And a significant number of patients require dose modifications, dose reductions, that is, and I think we should be very much on top of this and adjust the doses downwards as necessary so that the patients can get a good exposure to this agent. And not only that, in fact, you may know this, Jim, there are now, I'm told, close to 10 drugs, ALK inhibitors, in development in various stages.
Yeah, I can believe it.
So it is impressive that we see drugs one after another. What is remarkable about the second generation and the upcoming drugs is that we see responses in the CNS and very impressive durable responses in the brain. Brain is now increasingly a sanctuary site for these tumors that are well controlled elsewhere. And ceritinib has some impressive activity in the brain for the brain metastasis in this population. And I think we're going to see a similar range of activity, I suspect, in the new generation of ALK inhibitors that are coming on. So there'll be this is an embarrassment of richer story. It's a good thing for our patients. And I'm actually very, very optimistic about the ALK positive non-small cell lung cancer. We are really having now a number of options coming up for these patients.
Does ceritinib also target ROS1?
Yes, it seems. Again, we don't have very much data, but it seems like it is. And anecdotally, people have found some responses in the ROS1 positive patients.
Very good. Well, let's move on and talk about EGFR mutant disease. We've had erlotinib around for a number of years. We lost gefitinib. I don't know if it'll ever come back, but it certainly is also an active agent. But just like all these other drugs, you get 13, 14, 15 months progression-free survival, and then problems develop. You either get a T790M mutation or MET amplification or transformation to a small cell picture or HER2 or whatever. There's lots of different mechanisms of resistance. So there's always an effort to try to improve the responses. And there was a trial presented this year looking at comparing erlotinib alone with erlotinib bevacizumab, drug that's been used a lot in non-small cell lung cancer, whether it's EGFR mutant or wild type. So how did this turn out? Does the addition of bevacizumab add more than just cost and toxicity?
This is actually very impressive. I was a bit taken by surprise, Jim, to be honest with you. We have seen some improvement in progression-free survival when you add bevacizumab to erlotinib in previous trials, but this is very impressive. About 7 to 8 month improvement in progression-free survival with the addition of bevacizumab to erlotinib in EGFR mutant patients in the frontline setting. The question really comes back often to us. Why should we give EGFR TK inhibitors in the EGFR mutant patients in the frontline setting? After all, we improve disease progression-free survival compared to chemotherapy, but nobody has demonstrated an improvement in overall survival. So the Lux Lung trial investigators went back and did this analysis of the Lux Lung 3 and Lux Lung 6 data. Just to recap, Lux Lung 3 is a trial of afatinib, an EGFR inhibitor, comparing afatinib with cisplatin and pemetrexed. Lux Lung 6 is the same design, afatinib with cisplatin and gemcitabine. Both are only in EGFR mutant patients. So they pooled the data so that they'll have greater numbers.
Different populations, Asia and Western.
Yeah, and but basically EGFR mutant populations. They pooled the data. The bottom line is, in exon 19 deletion patients, in both the trials, afatinib actually improved overall survival by nearly a year compared to chemotherapy. And that was not seen with L858R.
I noticed that same thing, and I thought that was really odd because those are the two most common genetic abnormalities and usually the ones that you expect the best results in.
These two are fortunately the most common EGFR mutations that we see in lung cancer, and they also are the ones that are most sensitive. But we've known for quite some time, Jim, that the exon 19 deletion has a higher response rate compared to L858R. But we really, for convenience sake, we lumped them together and we forgot about that. But the differences are quite striking. So what are the implications for this? I think the facts are, this is an interesting analysis. And once again showing that not all mutations are the same. They behave differently because of different kinetics. The second thing is, this is the first demonstration that overall survival can be influenced by the appropriate use of targeted agent, here an EGFR inhibitor, compared to chemotherapy. Yes, it's a pooled secondary analysis, different studies, but still I think it really is an interesting point to make. Is it going to change the practice? I don't think so. And I think clearly a clear demonstration that EGFR TK inhibitors are appropriate frontline agents in EGFR mutant patients. I think increasingly the field is going towards using EGFR TK inhibitors in the frontline setting over chemotherapy. And the most important, I would say the most important two papers presented at the ASCO with regard to lung cancer are those, the newer inhibitors.
The mutant selective EGFR TKIs.
Two compounds, the AstraZeneca compound and the one made by Clovis, and both actually have impressive activity in T790M patients. In the past, we struggled to have any responses at all. And in fact, they have response rates of upwards of 50%, and they seem to be very selective. And more importantly, since they are mutant selective, they really don't inhibit the wild type receptor that much. So the toxicities are actually fairly mild, the conventional toxicities we see, the skin rash and diarrhea and all those things. But interestingly, you see a slightly higher incidence of hyperglycemia because of activation of the IGFR path, but that's something we can easily manage. So there's a lot of enthusiasm about this, and in fact, there are nice preclinical data to show that you can actually have very nice prolonged inhibition of these EGFR mutant cells in the preclinical models. If they really hold up, we may be looking at a very prolonged disease control in these patients. Hopefully, we can even cure these patients at some point. And I think the fact that if we have a better kinase inhibitors in this population, we can produce greater results, I think is a big, big news in this population. So
the results, as I recall in those studies, were superb in the T790M, but maybe not quite as good in the non-T790M. So are these likely to eventually replace erlotinib frontline, where T790M is usually a very small percentage of the patients?
Only time would tell. There are aggressive, plans are underway to investigate these agents in the frontline setting. But at least for now, we can take comfort that when patients develop progressive disease on erlotinib, afatinib, gefitinib, we will soon have an option. A number of trials will be ongoing in the coming years, and I think our patients will have a great opportunity here to participate in those trials.
Good. Couple other novel agents in the anti-EGFR and anti-VEGF pathways. Ramyoceryumab has been approved now for gastric cancer, monoclonal antibody that targets VEGFR2. And so the Revel trial was presented at this year's meeting, second-line therapy, docetaxel, Ramyoceryumab, or docetaxel placebo. Is this drug going to be a big player in advanced non-small cell lung cancer?
So Jim, that's a very, these two drugs are actually interesting, and the Revel study is one of the largest second-line study where patients with previously treated non-small cell lung cancer, both histologies, got randomized to docetaxel or docetaxel with Ramyoceryumab. And it turned out that the addition of this monoclonal antibody against VEGFR2 increased the response rates by about 10% compared to docetaxel, increased the progression-free survival by a month and a half, and overall survival by a month and a half, with a hazard ratio in the 0.85 region, if I recall. And these results were statistically significant. And the side effects, as you can imagine, obviously were higher with a combination compared to docetaxel alone. But I think it's important to keep a few things in perspective. Did the control arm do as well as they would normally do? Yes, 10% response rate is what we're used to seeing with docetaxel. Here we saw around 13% or so. And second, this is the first time I recall a VEGF antibody was tested in a squamous population. Here it accounted for about 23% or so of all the population, squamous cell histology. And we didn't see any untoward or unanticipated side effects that we are normally familiar, other than what we're normally familiar with VEGF inhibitors. And also, to put this in context, the last time we saw a positive study in the second-line setting was back in 2004 or so with pemetrexed. Yeah. And also, we've never shown a combination strategy to be better than a single-agent therapy in second-line setting. I have to say there have been nearly 100+ studies done with the docetaxel backbone in some combination. I'm just guessing here. And but seeing even positive results, even though it is fairly modest, I think it's remarkable in its own right. Now, a different and difficult question is that, are these clinically meaningful? Should we be paying for these expensive drugs for these modest benefit? I think that's a difficult question to answer. The society, the regulatory agencies, and others have to grapple with that. But it is important to keep in mind that we don't have very many options for this unselected group of patients. For targeted patients, they have very good options. Immunotherapy works in about 20% of those patients, but then there is a large group of patients who don't have a target, and I don't think we can expect huge benefit in this population. And if we can cut the cost down for the new drugs, I'm sure people will not have a problem with these even modest benefits. And
we're still looking for predictive biomarkers in the angiogenic pathways, and I've heard VEGF levels have been looked at. Does expression of VEGFR2 seem to be any kind of a predictive marker?
Not at the moment, nothing we know of. I believe that those studies are going to be done, and hopefully we'll have some group identified which has a higher benefit. And while we're talking about the biomarkers, we also learned that in the frontline setting, the use of anti-EGFR antibody, here is nivolumab, in squamous cell lung cancer patients compared to chemotherapy, that is addition of nivolumab to chemotherapy versus chemotherapy alone, produced once again positive results here. To me, it looks very much like what we have seen in the past with the addition of cetuximab in this population, the flex trial type of scenario. Modest benefit, not much improvement in progression-free survival, but an improvement in overall survival. So again, to put this in fair balance and perspective, this is the first time in a prospective setting we have shown an advantage in a squamous population with the addition of an antibody. Again, just like before, as we were talking about with Ramyoceryumab, nicotinamab produced modest benefits. And again, we have to confront the same issues. Is it worth the cost? The side effects are expected, but nothing unusual, nothing we cannot handle. Again, both these offer some benefit to unselected patients. Only time would tell whether there'll be a big interest in using these agents in the clinic.
So all of these are adding a few months here, a modest increase in objective response rates, but there is another class of drugs that looks even more impressive and has been a dominant feature at this year's ASCO meeting, and that is the subject of immuno-oncology. We've been hearing for several years about anti-PD-1 and anti-PD-L1 drugs, and I know that not only are they being looked at extensively in malignant melanoma, but also in a number of other areas, even head and neck cancer, renal cell carcinoma. And some of the most interesting data in the early presentations were the responses and the durability of responses in non-small cell lung cancer, whether it was squamous or non-squamous. So there have been some presentations at the meeting here with the Merck drug 3475 or pembrolizumab. MedImmune has an agent that is beginning to move through Medi 473, I think, the BMS drug, nivolumab. Where do you see this field heading in lung cancer?
Well, talk about, again, an embarrassment of riches. We have a number of drugs in development here, and there is a common theme here, Jim, that about 20% of these patients respond very well. And when they respond, their responses are fairly durable. The toxicities are fairly minimal. And this is actually quite striking. And there have been now a number of reports correlating PD-L1 expression with higher responses. And I'm not so sure whether we have really nailed this issue. What is clear is that if the PD-L1 expression is high, the response rates are higher in that group. But in the PD-L1 negative group, so-called negative group, still we see some responses. And there are problems with these assays. There are no standardizations. All of us who have been involved in these trials know that you can send your patient's tumor to drug X or company X, PD-L1 is negative, and then the turnarounds are the same tissue, it's positive, and patient gets on the other trial. So we need to optimize these, we need to standardize these assays. We need to know what to call them as positive or negative. So a lot of work needs to be done. And the real answer may not even be in the PD-L1 area. It may reflect the tumor burden, the specific antigens expressed. It may be much more complicated than what we think. But there's no question that these agents are here to stay, not only in lung cancer, but many other cancers. A radical shift in our thinking in the way we see, cancer therapy. So checkpoint blockade is going to be a key player here. A couple of things we learned in this session I thought were interesting, that the early upfront use of PD-L1 inhibitors and PD-1 inhibitors are going to be tested. We did hear about the upfront use of pembrolizumab, the Merck antibody, in previously untreated patients with metastatic non-small cell lung cancer, with some very encouraging results. And I'm very impressed with the early response rate we have seen and the time to disease progression. Again, this, we have to see whether this is going to be better than chemotherapy or chemotherapy followed by these agents. And in that study, the correlation between the PD-L1 expression and the responses were actually quite tight, quite nice. And it brings back one question: should we be looking at the tumor biopsy procured right before going on therapy rather than using archival material where things may have changed? So that brings another twist to the whole PD-L1 area in these things. And I think this field is going to go forward in a very rapid fashion. Other checkpoint blockade, other molecules involved in the checkpoint process will also be evaluated. Combination studies are being explored. People are going to come up with personalized immunotherapy using genome sequencing, identifying those antigenic peptide and customized vaccine therapy, and possibly in combination with checkpoint inhibition. So there's a lot of movement in this field. And so I'm actually very optimistic about where this is going. And, we still have a lot of work to do, convert the 80% who are not responding to these agents.
Is there any evidence that upfront chemotherapy increases PD-L1 exposure on the tumor cells, so that if you gave chemotherapy first and then consolidated with a PD-1 or PD-L1 antibody, that would produce even better
Not at the moment,
results?
to the best of my knowledge. I'm not convinced of the robustness of the data, but I think it's something that we may have to explore. Or the other way around, or the tumor is more immunogenic, there'll be a better chance to do this early on. Later on, the other pathways that emerge, so that makes the PD-L1, PD-1 axis irrelevant. We don't know that, and that remains to be tested.
Any correlation between response and lymphocytic infiltration of the tumors?
That's going to be tested in some of the trials, I understand. And, those are all fascinating questions, Jim, absolutely.
So we'll have to wait. You will have to wait around and find out. But I will not be waiting around
Can
to
I
find
say
out.
a few words?
You may.
Jim, I've known you for many years. You are an excellent and outstanding clinician. I've had the great privilege of working with you. And it pains me to realize that this is going to be the last interview that you'll be doing
retirement
on air
is looming.
Formally. And you are still in your 50s, I understand.
Yeah.
And you're going to have a wonderful retirement phase. And I've known you personally, professionally, and you're an awesome physician, a great moderator. You could get a job in a TV station anywhere.
Maybe.
But above all, you're a fine human being.
Thank you very much.
I wish you the very best in your retirement.
As are you. Thank you so much, Govindan. And thanks to all of you for watching this segment of Best of the Day. There is one more to come, my final Best of the Day at ASCO with Dr. Axel Grothe in GI malignancy, so be sure to check on that. And thanks again for watching all of these Best of the Day programs over the last 10 years. Thank you so much.